case of uterine perforation following repeated evacuation or tumor invasion of the merothelium and serosa from choriocarcinoma. The patient was a 40-year-old with 10 living children who presented with a history of recurrent vaginal bleeding, abdominal swelling, and pain. 5 months prior to presentation, she had undergone a section evacuation for a 2-month-old pregnancy, which was diagnosed as molar pregnancy. This was followed by 3 additional uterine evacuations due to persistent bleeding. She had received a total of 6 units of blood before referral to our facility. Histopathological examination confirmed a diagnosis of choriocarcinoma. She was pale. An abdominal examination revealed a uterus that corresponded to 20 weeks gestation. Serum beta HCG was above 67,000. She was commenced on EMACO regimen. Now, could the defect observed on ultrasound represent a uterine perforation secondary to repeated evacuation, or is it more likely due to tumor infiltration into the myometrium and or serosa? So let's look at the video. But before then, let's look at these features that distinguishes uterine perforation from tumor infiltration from choriocarcinoma in this case. In uterine perforation, the location is usually focal and commonly on the fundus or the corner, while if it is invasion from choriocarcinoma, it's often diffuse and may involve multiple sites. The margin of the defect is usually sharp in uterine perforation, and there will be abrupt discontinuity of the myometrial contour. In tumor infiltration, it's likely to be poorly defined, lobulated, and at times there will be nodular myometrial decay. The myometrial texture is usually heterogeneous if it's a tumor infiltration, but it's normal except where the defect is seen in uterine perforation. The content is usually solid or cystic, mass extending beyond or within the myometrium, replacing the normal anatomy of the myometrium. While in uterine perforation, there may be free fluid, maybe echogenic if there is blood clots or air, but there will be no distinct mass. There is unlikely to be vascularity in uterine perforations, but if it is tumor infiltration from choriocarcinoma, it's likely to be highly vascular, and the vessel architecture may be chaotic, and on spectral, the resistance is likely to be low with high velocity. Again, the serosal contour is likely to be focal in uterine perforation, and in early cases, serosa will be preserved here, but later it will be irregular due to tumor invasion. So now, let's play the video. As we can see, this is the bladder here and the field. Look at this irregular, heterogeneous mass here. And somewhere here you can see the normal myometrium here, thinned out here, and apparently replaced by a tumor here. Posteriorly here, you can see the myometrium here, apparently infiltrated by this tumor. So now, here you can see this is the uterine cavity here. Somewhere here you can see what looks like omentum here. See that? So again, look at the myometrium here and look at the cavity here and the omentum here within the defect. Not bowel here with a lot of shadowing. So our area of focus is here to be able to differentiate whether this is uterine perforation or repeated evacuation or tumor infiltration. Here you can see part of the bowel here, the omentum here. And look at the posterior wall of the uterine fundus here. So trying gently to define, you can see here this V-shaped appearance of the omentum here within a defect in the uterus. See that? Again, the omentum here, you can see bowel here, you can see bowel somewhere here, part of the myometrium here. Then you can see the invagination here of what I suspect to be the omentum. Again, note the area of the defect here and the anechoic content. So here, look at it here. So look at the continuity here, all through. So is this uterine perforation? You see that? You can see the defect in the serosa here, and you can see the defect in the myometrium here. And look at the cavity here. You see that? You see that? This is sharp, linear. It's not irregular. So all these are consistent with uterine perforation rather than tumor infiltration from choriocarcinoma. Again, look at it now. Look at the continuity of the ventricular cavity here, clearly. So this is the myometrium. Look at the breach in the serosa. Look at it here. So this is regular. If you apply color here, there will be no color uptake. We will just the uterine, the arterial vessels here, and the tumor itself. But you can see this well-defined discontinuity of the myometrium here and the serosa. So this is a case of uterine perforation as a result of repeated evacuation. Trying to make it clearer, you can see bowel movement here. Here you can see there is no movement because this is the omentum or peristalsis, right, in medical parlance. Here there is no peristalsis. So clearly you can see a discontinuous here. This is myometrium, this is myometrium. You can see discontinuous. Serosa is continued here. So this is likely a case of uterine perforation rather than tumor infiltration. Like a bullet wound, the entry point is small. This is the entry point, is small, well defined, while the exit point is larger. Here, look at the exit point is larger and irregular. Why? Due to the outwards force as the instrument exits the serosa. So, entry point 1.2, exit point 3.3. While this is regular and small, this is large and irregular. Of course, choriocarcinoma is a highly vascular tumor. So when you apply color and the pickup is not as expected, look at this pause repeated frequency, 1.3, which is high. But when it is reduced to 0.9, you can see there's better pickup. Better still when it is reduced further to 0.6 here, 0.3 here. So appropriate PRF setting is extremely important. While here the coloscopy may be just 2 or thereabout, here is like 3, but here is up to 4 because of appropriate PRF settings. It is good practice to always check the kidneys, especially if the pelvic mass is around 20 weeks and above, as can be seen in these patients. Look at hydronephrosis. The right kidney, with a normal left kidney. Some of the lessons learned in this case is that after an incomplete first evacuation, the subsequent attempts should be done under ultrasound guidance. Number one, if that was done in this case, probably the perforation would have been avoided. And number two, the features seen on this ultrasound scan were not in keeping with molar pregnancy because the lesion was solid. So I will now suspect choriocarcinoma or other conditions, and that will lead to early diagnosis and appropriate management. Thank you very much for listening.